कौन सी सर? पी पी पी, इसके नीचे पी. ओके, स्टार्ट. Good morning all. Are you able to hear me, sir? Yes, sir. Today's our topic is liver diseases. This topic has already been taken and probably it is a revision classes. So, what are the functions of liver?
Satvik, can you see the slide? Okay. Mayank, Jagriti, Satvik, now I think it is visible. Yeah.
Okay, so today's our topic is liver diseases. Okay, so what are the functions of liver? Liver is helping in metabolism of sugar, protein. It also helps in removing the toxins. It also helping in shipping of various protein. It generates the coagulation factors. So there are various important functions of liver. So what causes the injury to the liver? So there are many endogenous and exogenous factors that may cause injury to the liver. Endogenous factors are ischemia. In case of hypovolemic shock, in case of severe vomiting and dehydration, there can be overall ischemia which may cause vascular injury to the liver. Then the immune reactions. Immune reactions, especially in case of autoimmune hepatitis, primary biliary cirrhosis, primary sclerosing cholangitis, there are production of antibodies. The antibodies like ANA, anti-LKM, anti-soluble liver antigen, they are attack the hepatocytes and they may cause immunogenic injury to the liver. Then deposition of copper and iron in the hepatocyte itself. So when there is iron overload, it is called hemochromatosis, which may present with or without liver disease. It may present with other features of hemochromatosis like restrictive cardiomyopathy. It may present with pigmentation. It may present to injury to the other internal organs. And Wilson's disease, which may present as hemolytic anemia, which may present as cataract, which may present as neuropsychiatric manifestation with or without liver disease. Then exogenous factor of hepatic injury like infections, some medications like as common as paracetamol. Then some toxins, alcohol, they are also common causes of liver injury. So in case of a functioning liver, a liver with some or all functioning hepatocytes, what will happen when there is liver injury? They will release the aminotransferase and the level of ALT and AST is increases. Okay, but when the liver is shrunken, or we can say it is especially in case of cirrhotic, when patient is having long standing cirrhotic, so almost all of the hepatocytes are non-functioning. So in that case, there will be liver injury, but the enzymes will not raise. So what is AST and what is ALT? ALT is more specific for liver. AST can increase in other diseases also. So ALT is increased more than AST in most of the conditions, except in case of alcohol related liver injury, in case of alcoholic liver disease, in case of alcohol induced cirrhosis, and also in case of fatty liver, the AST level will be more than ALT. In all other conditions, any drug induced, toxin induced, viral, the ALT level will increases more than AST. And AST is also present in case of injury to the heart, skeletal tissue, RBCs. So, as I have told you, predominant AST elevation seen in alcoholic liver disease, in case of hemodialysis, hemolysis, in case of rhabdomyolysis, dermatomyositis, MI, in all cases, AST may rise. So, these are some conditions where mild elevation of AST ALT can be seen. Mild means up less than 5 times. So, if we say that the normal level is around 50, so if it is less than 250 or 300, but more than normal. So, in case of chronic hepatitis, in acute hepatitis, it may rise more than 5 times, but in case of chronic, ज़्यादा बढ़ता नहीं है. In case of other viral infection like Epstein-Barr, cytomegalo, hemochromatosis, medication, toxins, autoimmune hepatitis, other chronic diseases like Wilson, alpha-1 antitrypsin, celiac diseases, the ALT will rise, but not much. AST in case of alcohol-related liver disease, steatosis, fatty liver, or non-hepatic causes. Then, what are the causes of marked elevation of ALT? In the ALT rises to thousands, 1,000, 5,000, 10,000. It may rise up to many times. So, in case of acute viral hepatitis, the ALT will rise. In case of ischemic liver injury, it will rise. Okay? In case of toxins and drug, acute paracetamol poisoning, ALT will rise more than, may rise more than 5,000. Then halothane toxicity. Nowadays, halothane is not commonly used. Earlier, it is used in pre-anesthetic medication. Then acute Budd-Chiari syndrome. So what is Budd-Chiari syndrome? Can anyone tell me? So Budd-Chiari syndrome is infarction between the origin of hepatic vein and its entry into the right atrium. Yeah, correct. Or in case of hepatic infarct and artery ligation, ALT also rises. So, how to evaluate a patient with abnormal liver tests? Suppose a patient comes to us कि मुझे पीलिया है या I am having jaundice. So, how to evaluate? So, first we have to see whether it is acute or chronic. If it is acute, what the pattern look like, whether the pattern is hepatitic or whether the pattern is cholestatic. Okay, in hepatitic pattern, ALT will be increased and alkaline phosphatase will mildly increase. While in case of cholestatic pattern, the alkaline phosphatase is very much increased, GGT will increase, the direct bilirubin will increase. So that is cholestatic pattern. Cholestatic pattern usually seen in drug, then cholestatic pattern in case of any obstruction. So what to do in cholestatic pattern? We should go for some causes which obstruct the bile flow. Like in case of primary biliary cirrhosis, we have to go for antimitochondrial antibody. We have to take some drug history that can cause cholestasis. Okay? Like rifampicin. Rifampicin is prone to cause cholestasis and it is commonly used as a first line in tuberculosis. Then we have to go for ultrasound, MRI. But the best test for cholestatic evaluation is MRCP or ERCP. Then if it is hepatitic pattern, then we have to see what is the cause of hepatitis. So the viral hepatitis, we have to go for the viral panel, we have to go for the autoimmune panel. Then we have to see whether it is due to some ceruloplasmin, alcohol, drug history that we have to take. Then if it is chronic, again we have to see whether it is hepatic or cholestatic. The same. If in case of hepatic, ALT will rise. In case of cholestatic, alkaline phosphatase, GGT, direct bilirubin, that will rise. Again, in case of hepatic, we have to see the viral panel, whether there is any chronic hepatitis, hepatitis B, C can be there. Then other causes like hemochromatosis, Wilson's disease, autoimmune. Then we have to take history of those. In case of cholestatic, again we have to go whether any vasculitis. So antimitochondrial antibody is to be done, PNK is to be done, then ultrasound, MRCP, ERCP. Why PNK is mentioned here? What diseases you will find PNK in relation to the liver disease? What is the role of PNK? It is mainly for the vasculitis, CNK and PNK. But why it is written in cholestatic? Wegener, yes, but how does Wegener affect liver? It can affect the liver, but other common diseases, liver disease, any liver disease? Yes. Amit, you are right. It is primary sclerosing cholangitis. Okay, that may sometimes associated with positive PNK. Okay, especially when it is associated with ulcerative colitis. So primary sclerosing cholangitis can be a extraintestinal manifestation of ulcerative colitis. Okay, that may persist even after the successful treatment of ulcerative colitis. Okay, so in those cases, PNK is important. So this is the same that we have specifically found abnormal AST or ALT in acute hepatitis setting. Okay, so we have to see whether it is AST or ALT. In case of AST, okay, this chart is mainly for the hepatitis screening. Okay, if AST is more than 2 times of ALT, then definitely we have to take the history of alcohol. Okay, because only in case of alcoholic hepatitis or alcohol related liver injury and fatty liver, in all other condition, ALT will rise more than AST. So this is again the same thing. I have told about the hepatic pattern or hepatocellular pattern, then cholestatic pattern. So in hepatocellular pattern, the transaminases will increase. And in cholestatic pattern, the alkaline phosphatase, direct bilirubin, GGT, they will increase. The causes are for hepatocellular pattern, can be viral hepatitis, drug or alcohol induced hepatitis, autoimmune, NASH, hemochromatosis, and in case of cholestatic, any obstruction, whether gallstone, head of the pancreas, carcinoma, primary biliary cirrhosis, sclerosing cholangitis. So next, in case of liver diseases, jaundice. Okay. So jaundice, you know, it is just the yellowish discoloration of skin and sclera and mucous membrane in case of severe jaundice due to excess plasma bilirubin, may be direct or may be indirect. So jaundice appears when bilirubin exceeds more than 2 or more than 3 milligram per deciliter. Normally, what is the normal? It is 0.5 to 1.5, and from 1.5 to 2 it is called latent jaundice. The jaundice will be there, but it is not clinically apparent. So if it is more than 2, then jaundice will be appear. Cholestasis is just arrest of bile flow. So next is, what is hepatitis? Okay, if you are feeling any question at any point of time, you can ask. So hepatitis is, the origin of word is from Greek word that means liver, and itis means inflammation. So any inflammation of the liver is called hepatitis. So it is characterized by the presence of inflammatory cells in the liver. It can be self-limiting in case of infectious hepatitis. In most of the cases, like in case of hepatitis A or E, it usually is self-limiting. but it can progress to fibrosis and cirrhosis, especially in case of chronic hepatitis B, C, or other viral related hepatitis. It can occur with limited or no symptoms, but often lead to jaundice, poor appetite, and malaise, especially in case of infectious hepatitis. Due to hepatitis A or E, there is typical pattern of hepatitis. First, patient will have prodromal symptoms like severe anorexia, severe fatigability, malaise, muscle pain. Then there will be occurrence of fever, and along with fever, there will be severe rise in transaminases, and with the recovery, the transaminase may decreases, the fever subsides, and then there will be increase in bilirubin, and that may last for weeks to months. So when hepatitis lasts less than 6 months, we call it acute, and more than 6 months, it is chronic. So viruses are most common cause of the conditions. It may caused by other infection like EBV, CMV, toxic substances, and autoimmune diseases. So first is alcoholic hepatitis. Alcoholic hepatitis is most common cause of hepatitis. Excess alcohol consumption is a significant cause of hepatitis and cirrhosis. At least I think more than 80 ml of spirit per day for more than 10 years is associated with cirrhosis. In women, less alcohol is also associated with alcoholic hepatitis, and there will be rise in AST and ALT. AST rises more than ALT. The combination of hepatitis C and alcohol accelerate the development of cirrhosis. So in alcoholic liver disease, the AST will be more than ALT. The ratio will be more than 2:1 is suggestive, and 3:1 is almost confirmatory to alcoholic liver disease. So why AST rises more than ALT? Because alcohol increases AST synthesis, and vitamin B12 deficiency, that is usually associated with chronic alcoholism, that can inhibit the ALT. So AST will be more than ALT. Then toxic and drug induced hepatitis. So a large number of medication and other chemical agent can cause hepatitis. Antibiotics, paracetamol, CNS medications are commonly, anti-tubercular medication are also commonly causes hepatitis. The risk factors are increasing age, female, then previous patient of drug induced hepatitis, some genetic variability. Toxin and medication can cause direct cell damage, and they may induce structural changes. Ischemic hepatitis is injury to liver cell, as the name suggests, due to ischemia. The most commonly associated with heart failure, but it can also caused by severe shock or sepsis. Ischemic hepatitis, the AST ALT will be very high. ALT is very high, and the treatment is to treat the heart failure or treat the underlying cause. Then viral hepatitis. The ALT is primarily raised in case of viral hepatitis. It can raise up to thousands. Then there will be prodromal symptoms, bilirubin raised later on. When the patient is little bit improved, the fever subsided, anorexia, myalgia will be subsided, then bilirubin will raised. And usually it is self-limiting. The autoimmune liver diseases are autoimmune hepatitis, that can be type 1, 2, 3, primary biliary cirrhosis, primary sclerosing cholangitis. Autoimmune hepatitis, there are antibodies, some of the antibodies that are positive. It can be ANA in case of type 1 autoimmune hepatitis, it can be anti-smooth muscle antibody. The autoimmune hepatitis, there will be high bilirubin and ALT, but normal alkaline phosphatase. In primary biliary cirrhosis, there will be reverse. So presentation is, as I have told you, first there will be severe tiredness, anorexia. It is very typical of hepatitis, right upper quadrant pain, there can be Cushingoid facies and other stigmata of liver disease. The treatment is usually steroids. So this is a chart. It shows that when we see a patient of liver disease, so we evaluate the patient कि इसको क्या बीमारी हो सकती है. But when we don't find the common causes, like there is no history of alcohol, the viral markers are negative, it is not suggestive of any hemochromatosis Wilson or alpha-1 antitrypsin deficiency, okay, there is no evidence of NASH or fatty liver, then we must think of autoimmune causes, especially in case of young or middle-aged female in whom the disease, autoimmune disease is common. So first we have to go for the antibodies, ANA, smooth muscle antibody, anti-liver kidney microsomal antibody, LKM1, anti-mitochondrial antibody. Then if ANA, SMA and LKM1 is positive, we can call it autoimmune hepatitis. And in case of primary biliary cirrhosis, the anti-mitochondrial antibody is positive. Then if these two are common, autoimmune hepatitis and primary biliary cirrhosis, if both of these are not positive, ये सारे टेस्ट अगर नेगेटिव होंगे, ANA, SMA, LKM, AMA सब नेगेटिव है, then we have to go for some unconventional tests, ठीक है, in whom we can go for PNCA, we can go for F-actin, we can go for soluble liver antigen, and then we can, if there is no test is positive, we can say that patient may be a case of cryptogenic hepatitis or cryptogenic liver disease. So primary biliary cirrhosis, there will be increased alkaline phosphatase because the disease primarily in the biliary system. The biliary system obstructs the flow of bile and they cause the cirrhosis because of the backflow of bile. So the primary disease in the biliary system, not in the liver, but due to backflow, there will be cirrhosis. So there will be increased alkaline phosphatase and it typically anti-mitochondrial antibody will be positive. And as it is a autoimmune disease क्योंकि इसमें antibody positive है ना, anti-mitochondrial antibody, so it is a autoimmune disease, so usually associated with other autoimmune diseases, autoimmune thyroid disease, RA, Sjogren, sclerosis. It may, so if patient presents with primary biliary cirrhosis, we should actively search for other autoimmune diseases. So the complaints are lethargy, itching. It is common in middle-aged women. Almost most of the autoimmune diseases are common in female and in the young and middle-aged female. There will be malabsorption of fat-soluble vitamins. Okay? Vitamin A, D, vitamin E, K. There will be malabsorption. So patient may have symptoms of deficiency of those vitamins. Then there may be evidence of signs and symptoms of portal hypertension. They may have hyperlipidemia. So primary sclerosing cholangitis we have discussed. Okay? It is usually seen in patient with ulcerative colitis and also importantly in the HIV. There will be inflammation, fibrosis and strictures of biliary tree. It usually presents with jaundice, pruritus, abdominal pain and fatigability. The treatment is, first, how will we diagnose? There will be, bilirubin will be high and alkaline phosphatase will be high, but there is no evidence of primary biliary cirrhosis. The AMA is negative. And in primary sclerosing cholangitis, it is very difficult to treat. Okay? Because even after treating the primary disease like ulcerative colitis and HIV, the primary sclerosing cholangitis is persist. So we can try many treatments, steroid, cholestyramine, UDCA. Okay? We can treat the symptoms, but disease will progress. It is a progressive disease. Okay? We can go for liver transplant if there is end-stage liver disease. But After liver transplant also, in case of 20%, in 20% of patients, there will be recurrence. So primary sclerosing cholangitis is very difficult to treat and halt the progress. Next is NASH. NASH is nowadays increasing in prevalence. ठीक है, पहले NASH is very less prevalent. ठीक है, बहुत कम होती थी, but nowadays, especially in obese children, the NASH is very much prevalent. So it is non-alcoholic steatohepatitis. So usually patient will have other signs and symptoms of metabolic syndrome. ठीक है, like patient will be obese, the abdominal girth will be increased, there will be dyslipidemia, deranged blood glucose, deranged blood sugar, deranged blood pressure, there will be increased uric acid, there will be difficulty in sleep, snoring. There can be signs and symptoms of OSA. So 20 to 30% of NASH usually progresses to cirrhosis. Okay, the main treatment of NASH or metabolic syndrome is activity, increased physical activity, especially weight loss. Okay, so weight loss, control of lipids and sugar usually decreases the progression. Then little bit about the genetic liver diseases, Wilson's, hemochromatosis and alpha-1 antitrypsin deficiency. Hemochromatosis is autosomal recessive. There is increased iron absorption from the gut. So ferritin level will be increased and it deposited in various tissue, causing failure of function of those tissue. It usually presented with bronze diabetes. Bronze is because of the pigmentation, but also presents with arthralgia, hepatosplenomegaly because of deposition of the iron, and stigmata of liver disease. Testicular atrophy, if it is deposited in the testis, it may present with heart failure because of restrictive cardiomyopathy. So usually we go for ferritin level if it is very high. In case of patient with liver disease with very high ferritin, usually hemochromatosis, and with pigmentation, we usually suspect hemochromatosis. The iron binding capacity will be low because ferritin is very high. Iron बहुत ज्यादा है तो iron binding capacity कम हो जाएगी. In case of iron deficiency anemia, iron is low, so ferritin is low, so TIBC will be high. Okay, testosterone will be low due to testicular atrophy. There can be diabetes. There can be chondrocalcinosis on joint X-ray. And if we go for liver biopsy, it show iron staining. Hemochromatosis can be secondary to beta thalassemia and repeated blood transfusion. बार-बार blood transfuse करेंगे, so there will be iron deposition. So this is skin color of hemochromatosis. Okay, you can see in the right side there is pigmentation. Next is Wilson's disease. It is autosomal. It is also autosomal recessive. So there is defective intrahepatic formation of ceruloplasmin. Therefore, ceruloplasmin is a transport protein of copper. So therefore, failure of biliary excretion and high total body and tissue level of copper. Copper transport ही नहीं हो रहा है. So the ceruloplasmin level will be low and copper will be increased. Copper will be increased in the urine. So we go for 24-hour urinary copper, that will be increased. We can also go for the liver biopsy. So in hepatocytes, the level of copper will be increased, and we can go for level of ceruloplasmin, which will be low. Patient usually presented with cirrhosis. There will be typical Fisher ring in the eyes, hypoparathyroidism, arthropathy, ठीक है, renal tubular acidosis, Fanconi syndrome, and in case of CNS, there will be psychosis, extrapyramidal syndrome, mental retardation, seizure. Okay, so any young patient with neuropsychiatric symptoms, we usually suspect Wilson's disease. So any young patient with strange neurology and liver disease can be of Wilson's disease. So treatment is copper chelation with penicillamine. Zinc can be used sometimes. Okay, and ultimate treatment is liver transplant. but the CNS sequel will not resolve. So here we can see the typical Kieser-Fischer ring. Next is alpha-1 antitrypsin deficiency. It is autosomal dominant. It usually associated with alpha-1 antitrypsin lung disease, okay, the emphysema. So there is intrahepatic accumulation of alpha-1 antitrypsin that can causes the liver disease and may lead to cirrhosis. It is rare. It is not very common. So next is Budd-Chiari syndrome. Budd-Chiari syndrome is thrombosis of hepatic vein. It may be acute or chronic. It may be associated with hypercoagulable state. Because in hypercoagulable state, there can be thrombosis in hepatic vein, there can be thrombosis in the deep vein of the leg, there can be thrombosis of the pulmonary veins. So we should look for causes of thrombophilia. Okay? And malignancy should also be a cause of thrombophilia. So what are the presentation of Budd-Chiari syndrome? There can be nausea, vomiting, abdominal pain, tender hepatomegaly. So what are the treatment of Budd-Chiari syndrome? Patient may require shunt surgery or anticoagulant can also be used. Next is hepatocellular carcinoma. Risk factors of hepatocellular carcinoma are chronic viral hepatitis, Hep B and C, and cirrhosis of any cause. Okay, some toxins like Aspergillus flavus toxin. So alpha fetoprotein should be checked annually in patient with cirrhosis. Next is liver failure due to any cause. So these are stigmata of liver disease. So if a patient with chronic cirrhosis, we should look for these signs. Okay. The first is jaundice. Then in blood, there can be decreased clotting factor 2, 7, 9, 10. Okay. So factor 7 is having shortest half-life and usually helps in differentiating between acute and chronic. In acute, usually we see by prothrombin time. Okay. Then there can be hyperkinetic circulation. Respiratory, it is hepatopulmonary syndrome. Hepatopulmonary syndrome, how the patient will present? Patient will present with cyanosis and usually presents with fatigability, easy fatigability. Okay, so if a patient comes with liver disease and cyanosis and easy fatigability, we should see for hepatopulmonary syndrome. The simple test is we take the patient saturation, it is normal, then we ask the patient to exercise for few minutes, 2 minutes or 3 minutes. Then we again see the saturation. If it is the saturation will be decreased in case of hepatopulmonary syndrome. Then hepatorenal syndrome. In case of endocrine changes, there will be gonadal atrophy, gynecomastia, amenorrhea. Skin, there can be spider nevi and palmar erythema. Okay? There can be other like hypoglycemia, low albumin, infection and endotoxemia. Low albumin is a good sign of chronic liver disease because albumin has a long half-life. So what are the stigmata? In hands, we see the palmar erythema. Okay? Palmar erythema is due to vasodilation of the veins. Why there is vasodilation? There are many theories. Some say because of testicular atrophy, there is increased level of estrogen, which can cause the palmar erythema and spider nevi. Then there can be clubbing. Clubbing is not present in all liver diseases. In case of primary biliary cirrhosis, there will be, or sclerosing cholangitis, there can be clubbing. Okay, then Dupuytren contracture, there can be leukonychia, probably due to low albumin. There can be flapping tremor or asterixis. The flapping tremor can be present in other organ failure, like in case of CCF, chronic liver failure, okay, CO2 narcosis, the flapping tremor can be present. Then we can see for jaundice, spider nevi, gynecomastia, scanty body hair, scratch mark because of increase scratching because of the pruritus. Then abdomen, there will be ascites, hepatosplenomegaly, caput medusae, and hemorrhoids because of portal hypertension. Lower GI bleed can be there. Then testicular atrophy or small testes. So we should see all these signs in a patient with liver disease. This is very important in case of exam. Okay. You are saying that patient is having liver disease. Why patient is having liver disease? You can say that there is stigmata of liver disease. So these are dilated veins. This is caput medusae is a Greek god. उसके नाम पे हुआ है. So here we can see clubbing. This is gynecomastia. Then icterus. This is spider angioma. Next is ascites. So ascites is free fluid of accumulation of free fluid in the peritoneum. So when a patient comes to us with ascites, we should see the SAG ratio, serum ascitic albumin gradient. If it is more than 1.1, we can say that it is transudative ascites. Okay? Which may be because of renal failure, liver cirrhosis, heart failure, protein losing enteropathy, hypoalbuminemia, there will be transudative. And if the SAG ratio is less than 1.1, then it is usually exudative. So exudative can be in case of tubercular peritonitis, primary or secondary, spontaneous or secondary bacterial peritonitis. In case of lupus peritonitis, okay, the SAG ratio will be low. Sorry. So these are the causes of SAG ratio. Then management of ascites is usually, first is restriction of fluid and salt. Salt should be restricted. Okay. Then diuretics. Okay. High ceiling diuretic with or spironolactone. Okay. If it is not improved by this restriction and diuretics, then we should go for paracentesis. Paracentesis should be done with albumin infusion if the serum albumin is low. Next is hepatorenal syndrome. Hepatorenal syndrome is renal dysfunction without any intrinsic renal disease in a patient with liver disease. Okay, so there is liver disease and renal dysfunction. So it may be precipitated by aggressive diuresis. So in case of hepatorenal syndrome, the urinary sodium will be low, there will be no cast in urine as there is no intrinsic renal disease. Okay? After liver transplant, the renal function returns to normal. Then hepatic encephalopathy. Hepatic encephalopathy, we should always be careful about the precipitant. We should look for precipitant because there are some precipitant factor that will precipitate the hepatic encephalopathy. So what are the precipitant? It can be, the common are constipation, hypokalemia, GI bleed, high protein diet, any sepsis. So these are the common precipitant. We should look for these. So the treatment is gut sterilizer like metronidazole, rifaximin, then lactulose, and correction of precipitant factor. So this is all about liver disease. If you are having any question, please type or ask. Okay, thank you all. Good morning, sir. नहीं सर थे.
Step 2 would be W. Word.
Yeah.
It's all.
Shall I ask them? Good morning, dear students. Hope you are able to see the Word document about the case summary. Okay, yes, Satvik and Jagrati. So shall we start here? We'll be discussing a case. Yeah. Done. So today we have clinical discussion. If any issue in between, please let me know in one or other way, because last time there was some issue and I was not aware till the end. So the different modalities are working, including my phone. So please let me know if any issue. And Abhishek sir is helping us here. So today is,
Students, just give us 1 second. We'll be back.
मेरी वीडियो ऑन नहीं है तो भी उनको देख रहा है क्योंकि शेयरिंग स्टार्ट हो गई. Done. So again we are here and simultaneously I'm able to see the chat box if you have any queries in between. Otherwise we'll take up the queries at the end. As discussed earlier, this is the Tuesday 10 o'clock. So today is the psychiatric case discussion. So we all are here and hope you are comfortable at home. So today we will be discussing an interesting case. Here the case is 23-year-old female with undifferentiated schizophrenia with plica polonica and hypovitaminosis D, who's presenting with long-standing untreated psychosis and catatonic symptoms. So there are so many things to learn in this case, and again so many different questions for the different sort of exams, be it short notes, be it long notes, be it OSCE, be it MCQs, be it MBBS, be it beyond MBBS. Yeah, and there's some touch of dermatological problem, which is plica polonica. Here, this is a 23-year-old female girl who is unmarried. Presently, she was studying in B.Ed second year when she presented to us 2 years prior. And she was belonging to a nuclear family with upper middle social status, and she was residing in Alwar, Rajasthan. Here when she presented, then I was seeing her as a faculty and the other people were helping as a SR and JR, and especially most of work is done by Dr. Karandeep. This patient was admitted with us on 20th of August 2018 and there's some problems. So she was admitted till 8th of September for almost 18 days. Here the patient's parents were the informant and total duration was reported to us 6 years. Here the insidious onset was reported with somewhere episodic course, because whatever I'm just talking, this is for last 2 years. But yes, some problems started almost 6 years before, which I'll just cover in the past history. But while the total duration of illness is 6 years, because it's a psychotic illness, so we don't know how much is the improvement. Is it a complete improvement or is it some or other problems were remaining in between? But yes, the flow rate course was for 2 years when they presented to us. And what were the complaints from the family? This was a chief complaint: suspiciousness, sleep disturbance, abnormal behavior pattern, and muttering to self. Suspiciousness was almost for 2 years, sleep disturbance for 1.5 years, abnormal behavior pattern for almost 8 to 9 months, and talking to self or muttering to self for almost 2 months. Coming to history of present illness, and dear student, as my previous discussion, so I'll just brief up in between, but mostly I'll just talk after the presentation of this case summary. And this is a real case, so it gives us some connect in all the ways about the psychopathology to presentation to diagnostic workup to again management part and different issues. We'll just discuss everything. So you can also write down your queries in between in your copy or even in the chat box, no issue as ever you are comfortable. And here the patient was apparently maintaining well for 2 years prior. After the previous episode, because previous happened earlier. And when without obvious stressor or any preceding factor, she became suspicious to her friend of being closer to her and other friends. This is the friend was a girl only, but again there was some issue started as patient reported to family, and also suspected her of offending by disturbing the interpersonal relation between them by supporting other classmates. So some other friend was the target here, as she was saying that some was accusing her or troubling her, and again causing some problem with other classmates who were not liked by the patient. Gradually over the period, she also became suspicious of her neighbors of keeping a watch on her daily whereabouts and talking ill about her. Due to her above suspicions, she remained disturbed for most of the day and also was not able to have adequate sleep at night. Sleep was reduced significantly and she kept on roaming in home throughout the night. She also suspected people visiting her home of planning a conspiracy against her to harm her physically and asked them to leave her house. She suspected her family members, including her parents and brother, to be replaced by some stranger in their face and attire, and due to which she stopped interacting with them. Abnormal behavior patterns were also reported in the form of maintaining postures for long as she stood in one position for longer duration and did not move until and unless she was physically manipulated by her family members. She was also associated with significant decline. It was also associated with significant decline in self-care and would frequently refuse to have meals. Patient also remained mute for most of the times and also stopped accepting the meals, which was associated with significant reduction in her appetite. 1 to 2 days prior to admission, she was found muttering to self, and patient was sought from a treatment was sought from private psychiatrist, but she was not compliant on medications, and there was minimal improvement in her condition. Treatment advised by Olenza was the olanzapine 20, ziprasidone 80 mg, amisulpride 100 mg. These all three are the antipsychotics. Clonazepam 0.5 mg. Here they also reported us the past history of illness, which was around 6 years back. It was preceded by some psychosocial stressor and in the form of headache, suspiciousness, irritability, which lasted for almost 6 months. Patient then completely recovered within 1.5 months of the treatment, which they received from the private psychiatrist. After that, they stopped treatment. Details of the treatment was also not available, and again, they didn't consult to the doctor again. But again, entire course was almost 6 months. After that, the family report she was completely well. In the family, there was a history of schizophrenia in father, and father was also poorly compliant on treatment. Here, when we assessed the patient's body mass index was 23, and other examination findings were normal, except general physical examination finding. There was an entanglement of her hair because she was not able to comb, and that was the complaint as well as we have seen on the examination. Here, when she presented to our ward, then we tried mental status examination, but since the patient was not cooperative for detailed mental status examination, that's why it was done with a different method that is called Kirby's method. This is Kirby. This is for mental status examination for uncooperative patient. She was conscious, though she was uncooperative, and there were spontaneous acts present, but these were slow. She had an evasive gaze from the examiner. She was appearing perplexed, which was consistent. Eyes were open with reduced blink rate and staring gaze, and she responded to the examiner's command. She had normal muscle tone. She had poor emotional responsiveness and poverty of speech since she was not talking much. And later, as she cooperated in one or other way, so we had subsequent mental examination that was closer to the discharge. She was conscious, she was oriented to time, place, person, she was well clad, she was camped. Her psychomotor activity was slightly decreased, but better than previous findings. She, though the spontaneous speech was absent, but amount of speech was also reduced. She has constricted affect. Thoughts reveal that she had delusion of persecution. She has delusion of reference. Also, she had delusion of misidentification. I'll just detail of these all findings in the discussion part and subsequently. And the cognitive functions could not be assessed in detail and insight was absent. Here we have gone for the blood investigation. They were all were in a normal routine investigation, but here the vitamin D was less, which was 11. We also took the consultation from dermatology colleagues, and they diagnosed the patient with plica polonica, which is basically a disorder in which the hairs are irreversibly entangled, matted, in which people are not able to comb, and the only such solution is just to cut the hair or shave the head. This is the only way because many things don't work here. Many times because of the poor hygiene, and there are other reasons as well. But in this case, poor hygiene and poor self-care. With the above findings, this patient was diagnosed with undifferentiated schizophrenia, plica polonica, and hypovitaminosis D. We have gone for the treatment. I'll just stop here for a while and explain you the things, and then detail up the things further beyond this. Here, this patient, when presenting to us, the total duration of illness is 6 years. She has presented with the symptoms of irritability and delusion of, if we go to the past history, and there the suspiciousness was mainly reported, but again, this was 6 years before when she was around 17, with irritability, somatic symptom, and suspiciousness. So possibly that was a psychotic phenomena, and this was a psychotic episode, or maybe this was the beginning of the schizophrenia, and again florid symptoms improved with the treatment, but still the some or other deficits were continuing, which were not much of the concern to the family. That's why, as per them, she was maintaining okay. But when she presented now to this admission, then for almost 2 years, what are we getting? There was delusion of persecution, that people are suspicious. She's suspicious about the people, that people may harm. And also people are talking about me, and talking ill about me. Here, because this was a false, firm, unshakable belief, that's why labeled as a delusion, out of keeping her socio-educational, cultural background. Persecution was because the fear of harm by the people, and again reference that people are referring to me or talking about me. Here, additionally, she mentioned in the history as well as in the detailed examination and workup, that my parents are replaced by someone, they are not my real parents. This was basically delusion of misidentification. In your book, you may find in the misidentification syndrome or Capgras syndrome, where the person sees someone and finds someone is the stranger, someone is different than the normal as somebody is visible. There are different forms in a way, but persons say that somebody is replaced by someone and then doesn't trust that one is my own friend or my family. But here she started having these with the father or the family members, but not the outside people. Simultaneously, in this case, we had catatonic symptoms because this patient was standing in the similar position for hours, which was not the normal work and chores in one or other way. She was talking very less. So in a way, the things started with some catatonic symptom, but specifically posturing, that she's maintaining the same position or same posture for long hours, and simultaneously mutism. And that's why there were catatonic symptoms as well. But in this patient, while the label was undifferentiated schizophrenia, dear student, in the recent nosology, there's no subtyping of the schizophrenia in DSM-5, and going to be in ICD-11 as well. But currently we are following ICD-10 for all logistic reason. There are subtypes. So just because even the MCQs come of the previous bank, or even remaining the working patterns of different places. So why undifferentiated? Because she was fulfilling catatonic symptoms, she was fulfilling positive psychotic symptoms in form of delusion, persecution, delusion of misidentification, delusion of reference, and also the poor functionality, poor self-care. These all were the negative psychotic symptoms. So since one is having the symptoms of different domains, that's why also one can label undifferentiated schizophrenia. The other time of labeling undifferentiated schizophrenia, when somebody is fulfilling the criteria of schizophrenia but not fitting into any category. So when the symptoms are more than one category or not fitting into any category, then both the time people do label undifferentiated schizophrenia. Plica polonica, as I mentioned you can even go through with that. And again, it's interesting to see that, and very difficult to manage in a way because somebody has to shave their head. It's not an easy thing in the female or even in the male, but in the female is more difficult. But again, we had to explain to them. But again, then particularly if the entanglement into the some section of the hair, then definitely that part can be trimmed or shaved. Otherwise, if it is an entire scalp is involved, then entire scalp has to be shaved. But in this case, in the ward, we persuaded a lot, but patient didn't agree. And again, we were also worried about her psychological reaction because here patient is not having inside, and again, out without consent, if we even with the family's insistence, we even try something, but patient may be disturbed in both the sides. So, but at home they tried, and again, they could trim the bigger section of the hair just to prevent the further problems, and things moved with that. Hypovitaminaceous D was also important finding here because many times it has been seen if the vitamin D deficiency is there, including other vitamin deficiencies, but especially vitamin D, then basically people don't respond that well with given antipsychotics because the problems are there in terms of the mechanism of action of the medications involves the vitamins substrates because it has the role on neurotransmitter vesicle formation and other neuromodulation. Here when the patient came to us, then we started olanzapine 10 milligram morning and evening. Lorazepam was initially started with injectable 2 milligram thrice a day IV, and within 3 days or even within 2 days her catatonic symptoms improved completely. She was not having a particular posting, mutism and other type of the disturbances related to catatonic symptoms improved, and thereafter we shifted her to a tablet form of lorazepam, and that also we gradually tapered. Here in the case, as the family told us, the problem was the compliance. She was stopping the medications several times earlier as well before coming to us. So that's why we thought to go for the depot preparation. Depot are the injectables which can be injected once in 2 weeks, 3 weeks or 4 weeks that remain effective. So it's useful in a patient where the compliance problem is there and discuss with the family. So that's why we have gone for the first generation antipsychotic. This is flupentixol. And here what I want to just say, whenever we go for the depot preparation, it takes couple of months to have the effect, right? Just to have a steady state after almost 4 dosages and then to have the effect. So that's why we were giving cover of olanzapine, which is a tablet form, may work just from the day one in some or other way. We have also added the supplementation for vitamin D once a week, and we have also started the non-pharmacological treatment, which is very important in this case as well as any given case. First and foremost, medication should be given under supervision by family member. Psychoeducation, family members were educated about the illness that she is suffering from schizophrenia. What are the symptoms? What are the causes? What are the potential treatment? What are the potential benefits? What happens if we don't give the proper treatment? What happens if this remain untreated? And again, the further course management issues. And along with their queries were also resolved. Why it is important? Because in any given case, if people know, then definitely they cooperate better, they supervise better. But unfortunately, many disorders people don't know, including family members don't have much knowledge. So definitely the treatment suffers. And here always, here the things also started at the early age, almost at the age of 17. We also explored for father's illness. Why? Because if any family member remained untreated or ill, then definitely we are not going to have a good course in this patient. For all logistic reasons, because the family members won't be that much equipped and there may be someone symptomatic near to her. And again, she may also be concerned about the health of the other family members. So we started treatment for father. We were very clear about that if he remains on treatment, then we have better hope for the patient. But if he doesn't take properly these medications, then also the problems are going to be there only at home. So we have started treatment. Dermatology consultation was taken, as I mentioned you. But again, the nitty-gritty was there between the psychiatry and dermatology, and whatever they advised us, we followed, and we were also going to ask them different things. Here, as the patient was having negative psychotic symptoms as well, means poor interaction, poor functionality, poor self-care, reduced drive to social functioning. So in a way, we just work with the activity scheduling in a way, just how to keep her engaged, how to keep her physically active from morning to evening. This is a timetable basically, and whenever she is trying to go in those activities, then we were praising, and family member will also advise how to have the reinforcement basically whenever she is trying, how to appreciate her and how to motivate her and how to support her. And gradually these things are going to be better. We also tried with the ECT workup, electroconvulsive therapy, but again, here it was not needed because patient improved. Initially, we were a bit apprehensive with the course and again given treatment. The patient at the discharge, once we have seen this is first, we have just also rated the patient with the different rating scales. First one is BPRS, this is brief psychosis rating scale. At admission it was 81 and at discharge it was 27. So it was a significant improvement in that. Simultaneously, the next scale was BFCRS, this was Bush-Francis catatonia rating scale. At admission, it was 16. At the discharge, it was 1. So there was significant improvement as per the family member and as per our observation. And the patient was discharged with olanzapine tablet as well as flupentixol depot preparation. And lorazepam was tapered and stopped. Vitamin D was continued. During follow-up, she didn't report further improvement because the remaining symptoms were there, as you are seeing this. Psychotic symptom related scale BPRS, the first one, the 27 score was there at the discharge. But we have seen that there was no much further improvement at the discharge beyond this. So we thought to add another medication or to switch to this medication to the other. Why? Because with the olanzapine, patient was complaining weight gain. She has gained almost 10 kg of weight. In the monitoring, we have found that was also a concern to us. So we thought to add with some other medication. There we have gone for trifluperazine. This is first generation antipsychotic, and it was added as 5 milligram and hiked up to 10 milligram, and on which she completely improved. And this was also a reason because the flupentixol depot was stopped because she was once compliant, so there was no much problem in the compliance, and again they were also not getting the injection in their hometown. So both were the reasons. So here also we have from flupentixol we have gone to trifluperazine and tablet preparation. And as I mentioned, since weight gain was reported on our investigation as well as her reporting, so that's why we have planned to hike up the trifluperazine only and gradually to reduce and stop olanzapine, in which she can be maintained on one medication because already she is maintaining well for almost 1.5 years. In significant improvement on almost substantially well for almost 1 year. In view of these weight gain related issues, we have also advised the lifestyle modification, dietary changes, and again plan is to taper and stop olanzapine gradually and also to seek endocrinology review if needed. But why didn't we go for first place endocrinology review? Because here the olanzapine is the one culprit and again remaining symptoms was the second, because since she was not interested to do much, that's why she was not trying many things. Here, as I told you that we have started tapering the medication, so olanzapine is reduced to 7.5 from, as in the ward it was 20. Trifluperazine we are presently keeping 10 only, but again if needed we will hike up this medication. This is with a combination with trihexyphenidyl 2. Here we are having the plans with how to prevent psychotic symptoms again, because this person had around 6 years before, then improved, then for almost 2 years, and because it's some or other way early onset schizophrenia started before 18, so the longer course is tricky, difficult. So regular supervision, proper psychoeducation, proper medication compliance, proper follow-up is very, very, very important. But again, we have also advised the family how to keep the lesser stress or reduce stress in ongoing thing, how to address the crisis, how to supervise the compliance, how to report if any issue. So in one or other way, if remain, then definitely we will be preventing the further relapse. And yes, if some subtle symptoms start, say sleep problem, irritability, that all, then also we are supposed to hike up the trifluperazine or address those symptoms with some other remedies. Because of those symptoms remains, then she may again come with psychotic symptoms or psychotic illness. Here also Copil skill training was imparted to the patient family, that how to handle the day-to-day stressor. I'm coming to the learning point, but before that I'm coming to the first section or initial section. Again, here what were the issues when we started our discussion here, or why to think about this patient? Why is it important to discuss? One, it was a longer duration of untreated psychosis, because even in this 2 years, the treatment was not there regularly. They approached to us, then just few months before they started some treatment. Two, as reported by family member that she stops the treatment, that's why we are not giving to compliance was the issue. And on that of family members were not having much knowledge about the illness, though the father was also suffering from schizophrenia, but they were not having any information much about the illness. And here, as I mentioned, that father was also not taking the treatment properly and she was having active psychotic symptom. So that was also one problem in the case. That's why it's important to address the problems of the family member because they are the support persons. And third, as I mentioned, the poor physical state. She was found with poor self-care, untidy, and developed plica entanglement of the hair. So in a way, the physical care was not appropriate. So these all were the issues in this case. And again, what did we learn in this case? And I'm coming to your question. Yeah. Here we learned this with any problem, in-depth assessment is very, very, very important. Why? Because just assessing the people in just 5 minutes, 10 minutes, 20 minutes won't help here because the illness is a longer one. And on the top, one was not improving. So there must be several reasons. The choice of medication and also the different psychosocial modalities are very important. Two, with comprehensive assessment, yes, treat the symptoms which are more important. Yes, catatonic symptoms were more important because if she remains in the different positions, posture, lack of interaction, then problems are going to be multifold. So we address the catatonia first, and again, coincidentally, that improves faster than the other components in psychosis as well. That's why she improved with catatonic symptoms. Two is again also take care of the physical problem because many of the time people with severe mental illness or with schizophrenia have some other physical problem, and if these physical problems are not addressed properly, then definitely the course is not going to be good. Here the physical problem was dermatological problem as well as endocrinological problem in form of hypovitaminosis D. So in a way, we try to handle those physical problem with the liaison with our colleagues in different departments. So one person is with us, so let's take care all the things. Third, yes, family should be healthy. That is very important thing. I'm sorry to say, bacha look, many times this part is missed. Be it any specialty, any clinic, because we just forget the family member. We just focus on the patient, but not. Yes, one should focus on the patient, but equally important, people should focus on the family because yes, if my family is healthy and strong, then definitely there are more chances that I may remain healthy and strong. And again, this is the patient, so family is the support person. And many times they don't talk about their health and neither we ask. So it's the father's illness and again our insistence, and we started treatment, we facilitated everything within the ward only, we prescribed and he started taking, and we could also observe him. And I still remember the patient was in somewhere semi-private room of the first floor because till that our ward was on the first floor. So it was one seat, semi-private, father was there. And whenever I was going, they were sometime taking lunch or sometime what, but mother was only person talking. Father was hardly talking, or whenever I was talking, father was looking somewhere here and there. So we had a doubt there's some problem. And on exploration, we found his father also has schizophrenia. Then what about the treatment, things of that nature? So yes, comprehensive assessment. Yes, care of the physical problem. Yes, care of the family. Coming to the most important lesson. Yes, patient don't need just medication. They need everything. So in a way, comprehensive workup for biological, psychological, and social causation. Again, whenever we are treating, then again biological, psychological, social. In a way, biological were the medications which we tried in this case. Psychological, as we started teaching her the coping skills, and again when handling the problems in the life, and again different type of the psychological work, be it regarding compliance, be it regarding the other issues, regarding day-to-day thing, regarding negative symptom, regarding self-care. Social is outside the patient or outside me, whatever it is social, including families also comes in the social only. So if we try to help the people with the different modes of biological, psychological and social modalities, then the results are much better. And same, this case is almost well for almost for a year. And yes, observation is very important in the longer runs. Here, since patient is observed, yes, there's a weight gain. and then we are concerning the weight with the weight gain, though she's fine absolutely, but again, since she is having weight gain, the first culprit is olanzapine. So you know, biggest risk or highest risk of weight gain with psychotropic medication is clozapine. It's antipsychotic. So among antipsychotics, highest risk of obesity or weight gain, clozapine. Second highest, olanzapine. So this case was with olanzapine. So let's taper olanzapine, and eventually she is better with trifluperazine. And again, as I mentioned in the management part and the learning point only I'm speaking, that since the compliance problem was there, so initially we tried to give the depot preparations. There's an injectable which may work for almost 1 month or more than that. So this injection was given, and again, since the stable dose of antipsychotics were going, she was improving. So not just waiting with the pills only, because many times there's a problem in taking the tablets. And again, working with her rehabilitation, her functionality, her educational thing. Fortunately, her brother is educated. He's, I think, medical rep and friend of one of our SR in the same hometown, sharing in one or other way. So one is also looking after about her rehabilitation part, functionality part. Otherwise, what may happen after a few years, she'll be depressed that what the hell has happened with me because of this illness. I could not study, I could not go with my dreams. So yes, that part also should be taken care properly, which we tried. And again, since the weight gain was reported, so our concern, taper olanzapine, monitoring, repeat the different investigation, and again dietary modification, again lifestyle changes. So in a way, this is a multi-model approach, and again comprehensive treatment for a case with schizophrenia who has developed the physical disorder like plica polonica, and again added hypovitaminosis D. So the learning is comprehensive management, and again thoughtful management plan, and again proper follow-up. So that is the hurt in this case, and that's why the good result. Unlike many cases, we don't get very good result in the chronic mental illnesses. But again, the management is again proper, then many people improve to the greatest extent. Thank you very much. I'm here for your question. We were slightly brief in the discussion in the presentation, but again, I'm happy to answer your queries related to phenology, related to diagnosis, related to management. So dear students, please post your question in the chat box. I'm with you. Hope you are able to see and you were able to hear. Let me brief you about the subsequent program in next 1 week from my side. Be here for some time. So Friday will be the class from my colleague, but coming Monday will be the class from my side, where the title is Holistic Management in the Case with Psychiatric Illness. And on Tuesday, we have the clinical discussion. So on the Tuesday clinical discussion, we'll discuss about the depression, treatment-resistant depression in a case with elderly male. So it was a geriatric depression with lot of psychosocial problems. And again, in the Monday, we will just discuss the topic with case-based discussion about this holistic treatment works. I'll try to connect these 3 cases in this and that way. That's why you just try to remember some or other things. And again here, read about the delusion of misidentification. There's a 4 types given very beautifully in your Neeraj Ahuja book, just half a page. The different forms of the delusion of misidentification syndrome, or misidentification syndrome it's called. 2 is also read about the medication, and again their related propensities and the side effects. And definitely the bigger section is the schizophrenia, because everything is covered in this and that way. Yes, the last is the interesting disorder, plica polonica. If you have seen in dermatology, then fine, but if you are not, then please read up. Lot is given on the web, and again maybe in your books as well. If no more question, I'll just wait for a few minutes. If some question, if no more question, then we can disperse, and you can then connect for the another class. But I would insist, please keep reading, learning, discussion, because the time is going like anything. We were hoping everything may normalize within a month, but I'm sorry to say we are on the fourth month now. Things are not normalized in terms of COVID-related problems and issues, and may take a couple of more months on that of the other issues. So it's still your goal to keep yourself fit, happy, peaceful is yes first. Your studies, your family time is also first. So see to that in one or other way. If any issue, please connect with any one of us, your mentor, us, counselor. But again, stay in touch with your family and friends. Keep yourself happy, chirpy, bubbly. And thank you very much. God bless. I haven't received any question, but you can drop your questions. Thanks.
Hello, good afternoon, sir.
माइक ऑन नहीं है.
Hello, good afternoon, everybody. Am I audible? Great. Should we start or should we wait for some more people to join? There are currently 42 people who have joined. Five more minutes. That's a huge time. Let's wait for 2 more minutes. Meanwhile, have you guys started reading community medicine and family medicine? Anybody reading any other book except Park? Or nobody is reading anything? Lecture में जितना बता दिया उतना काफी है. So yes, there is one more book which is now in the market. It comes by the name of IAPSM textbook of preventive and social medicine. So this textbook, this is a new textbook and it is written in a much more better way. And more than 200 people from all over the country have contributed in this book. It is written in a bit more, less dry manner. There is less chances that you will go to sleep. There are more graphs and diagrams in this book. And in fact, from our department also, 4 people have contributed in this book. So if you want, you can consider reading this book also. Or Park is also fine. Park also has all the information. This new textbook also has all the information. Yes, either Park or IAPSM textbook. Don't read both. That will be too much. Okay, so let's start. There are 61 people who have currently joined. Let's quickly recapitulate what we had done last time so that meanwhile others can also join. So we had started reading about NVB-DCP, that is National Vector-Borne Disease Control Program. And in the last class, we had seen mainly about malaria. There are many strategies for control and elimination of malaria. We had seen the National Strategic Plan. What is the definition of elimination? What are the ways in which districts are classified? And what are the various strategies for malaria elimination? Similar strategies are there for all the other diseases, and hence all of these diseases are clubbed under the main program called as NVB-DCP. There are few changes, few differences between the programs, between the approach in which we go about for control and elimination of various diseases. Like for dengue and chikungunya, we are still not talking about control or elimination. They are so widespread and we still don't know their epidemiology in detail that we do not talk about control and elimination of dengue and chikungunya. What we're talking about are management, clinical management of both dengue and chikungunya. Clinical management basically means how to diagnose and how to treat. Then for filaria and Kala Azar, we are speaking in terms of elimination. And for Japanese encephalitis, we are not yet speaking of elimination. We are still in the phase of prevention and control. Right? So last month I had shared some MCQs with you. So let's start with the review of those MCQs. Many slides. We had already seen all these things about malaria. Okay, so these were the MCQs that we had shared. Let's go one by one. The first is the machine shown in this image is used for. So this is the machine for fogging. It is not used for indoor residual spray, it is for fogging. Correct answer here is ULV fogging. ULV starts with ultra low volume. It means very fine particles. And 22 people have got this answer right. Next question was, India was able to significantly reduce malaria burden from 75 million cases in 53 to 0.1 million cases in 1958. This was due to the use of, the correct answer here is DDT IRS. IRS is indoor residual spray. Indoor residual spray is घरों के अंदर दीवारों के ऊपर DDT छिड़कना. That is DDT IRS. Again, 19 people out of 31 answered this correctly. Next question was, the most important method of vector control is. So the correct answer here is source reduction. See the way the question is asked, most important method, yeah, most effective method for vector control is source reduction. Removal of water. There should be no logging of water. Next is identify this particular mosquito. Now, when we are talking about identification of a mosquito, adult mosquito, first thing we have to see is whether it is Anopheles or not. So if the body of the mosquito is not at an angle of the surface, it is not raised from the surface, it is towards the surface, then it is definitely not Anopheles. So what remains are Culex, Aedes and Mansonia. So between Culex, Aedes and Mansonia, one of the most important criteria for identification of adult mosquito is presence of bands on the body. And when there are presence of these kind of bands, as we can see here on the body, these kind of bands, when they're present, this is classical of Aedes. And majority of you, 25 of you, got this answer right. Next is indicator of operational efficiency for malaria surveillance. Operational efficiency मतलब काम सही से हो रहा है या नहीं हो रहा है. Surveillance का काम घर घर जाके जो slides बनाने का काम होता है वो सही से कर रहे हैं या नहीं कर रहे हैं. And for operational efficiency, the correct answer is ABER, Annual Blood Examination Rate. ये सारे indicators जो हैं ये हम last lecture में पढ़ चुके हैं. I have also shared the slide with you on the Google Classroom. उसमें इसकी details दिए हुए हैं. Next question is, as per the National Strategic Plan 2017 to 22, malaria elimination is defined as. The correct answer here is API less than 1 at district level, not at state level. Before 2017, it was state level. Since 2017 onwards, now we are talking about district level. API less than 1 at district level. The correct answer is B. Then as per the NSP 2017 to 22, objective is to achieve. So the correct answer here is A, 100% screening of malaria suspect fever cases. Before 2017, this was 85%. Now it is 100% screening of malaria suspect fever cases. Then as per NSP, LLINs should be used in which areas? They should be used only in those areas where API is more than 1. So the correct answer here is A, in the pre-elimination phase, that is API 1 to 2. Next is the most widespread species of Anopheles in India is. Answer here is D, Culicifacius. This is a very important and frequently asked MCQ. Which is the most frequently occurring species in India? Answer is Culicifacius. If the same question is changed to which is the most widespread species in urban areas, then the answer will be Stephensii, Anopheles stephensii. Then malaria vaccine currently being used in some African countries. Answer is RTS-AS01. Almost all of you have got this answer right. So, as it is said that you guys are very much updated with what is happening recently, but you also need to know what has been happening in the past. RTS-AS01 is still not licensed in India. It is licensed only in 3 countries in Africa, that too on a pilot basis. There are many reasons and controversies for it. We will not go into details of that right now. Great, so 2 students scored maximum, that is 10 out of 10, and 2 students scored 9 out of 10. So not bad, good performance. Right. So coming back to our other programs, next, let's talk about leishmaniasis, also called as Kala Azar, black fever, or Espundia. Okay, so we have already seen about the problem statement in our previous classes. Just quickly, in India, there are few districts. Yeah, I have written here, there are 54 districts in Bihar, West Bengal, Jharkhand, and those areas where visceral leishmaniasis and PKDL is currently seen. Mucocutaneous leishmaniasis is not seen in India, so we will not be talking about that. So these are the areas, and there are 4 categories as seen by these 4 colors, category 1, 2, 3, and 4, based on which districts are classified. So again, like malaria, for Kala Azar also, the classification is done at district level. Now this is important from MCQ point of view because there is at least one disease out of the NVB DCP which is not classified at district level. We'll be seeing it shortly. So Kala Azar is also done at district level. And the name of the program, subcomponent of NVB DCP, it is called as Accelerated Plan. Like for malaria, we call it NSP, National Strategic Plan. For Kala Azar, we call it Accelerated Plan, again for elimination. It was given in 2017 with the target year of 2020. 2020 has come, we have not yet achieved the target. The next targets are yet to be defined. So the elimination definition for Kala Azar is less than 1 case per 10,000 population at block level. So all of us remember that it is less than 1 case per 10,000 population because this definition is going on since 2002, since the health policy of 2002. However, another thing that we have to remember is the elimination for Kala Azar is defined at block level. All the other eliminations under NVB DCP are defined at district level. Only the Kala Azar elimination is defined at block level. When we're talking about program efficiency and management, when we are trying to show it diagram wise, we show it at district level. But when we're talking about elimination target, we talk at block level. This is an important MCQ point that you need to remember. What are the strategies? What are the different interventions that are recommended for Kala Azar? So our age-old secondary prevention strategy, that is early case detection and complete management. Early case detection using the case definitions of suspect, probable, and confirmed cases. Again, they have been covered in your full Kala Azar classes, and complete case management. Besides cases, we also have to target the integrated vector management and vector surveillance. How to do vector management? Same as we have seen in malaria, using larvicides and adulticides. Vector surveillance is entomological surveillance. What are the species of the mosquitoes, whether they are resistant to any of the pesticides, all those kind of surveillance also need to go hand in hand when we are targeting an elimination strategy. So there are only 2 technical things that we need to remember, that is early case detection and complete case management, and next is vector management, integrated vector management. All the other components are mainly related to the management aspects. So supervision, monitoring, surveillance and evaluation, human resource development, training of human resources of how to do diagnosis, how to manage cases, how to identify cases, and advocacy, communication and social mobilization. What do you understand by the term advocacy? Advocacy basically means you try and talk to policymakers into giving more resources, more funds, more money towards the program. That is called as advocacy. Communication is an overarching term, which means that there needs to be 2-way communication between the policymakers, the program implementers, and the final clients who will be benefiting from the program. And social mobilization is we empower the community, that they start demanding whatever resources they need for prevention of a particular disease. So they are very similar terms, but there is a fine line of difference between all these 3 terms, and that is why they are also written together, but they mean something different. So again, I'll repeat once more. Advocacy means we try to request, we try to present our case to policymakers that why funds and resources should be given to our program of interest. Communication is a two-way dialogue in which the policymakers, the program implementers, and the clients all are able to talk to each other in an effective manner. And social mobilization is when there is adequate awareness, adequate knowledge in the community so that they can start demanding about what resources they require in order to eliminate the particular disease in their area. So these last 3 points, supervision, monitoring, surveillance, evaluation, human resource development, and ACSM, these 3 points you can write in any program. Whatever program is asked to you, whether it is an infectious disease, non-infectious disease, whatever control strategy you want to talk about, you can mention these 3 points anywhere. They are non-specific points, but very, very important with respect to program implementation. Right? Any doubts here? Right. Next we come to lymphatic filariasis. It is also called as elephantiasis, or in Hindi it is called as hathi paw. And the definition of lymphatic filariasis is, elimination definition is less than 1% of microfilaria prevalence. So lymphatic filariasis burden is very high in India. India, in fact, contributes to almost as high as 43% of the global burden. And currently it is seen in some 256 districts across 21 states in India. When we're talking about Kala Azar, it is currently seen in 54 districts. And lymphatic filariasis is seen in 256 districts across 21 states. So this is the distribution of filariasis endemic states, districts in India. As we can see, major burden of the disease lies in areas of Uttar Pradesh, Bihar, West Bengal, Jharkhand, Chhattisgarh, Maharashtra, Telangana. The entire east coast, almost the entire east coast is suffering from filariasis, and some areas of Gujarat. Right? MDA stands for Mass Drug Administration. TAA stands for, we'll see shortly what they are and what do they mean. Okay, so this slide, okay, this is a better slide. Right. So again, just like for malaria, we call it as NSP. For Kala Azar, we call it accelerated plan. Even for filaria, we call it an accelerated plan for elimination of lymphatic filariasis. And again, initially, the target for this accelerated plan was 2020. Now it has been pushed one more year to 21. And maybe because of COVID-19, it will be further pushed by 1 year or more. Please take a note of this logo. This is a logo specifically designed for filariasis. And this logo has 2 hands, one hand in orange color giving some sort of a tablet to a hand in green color. This tablet is the tablet of mass drug administration. Okay, so this logo can be asked to you in your exams as an MCQ to identify which program this is associated with. In the options, you might be given filaria, or you might also be given NVB DCP. So you need to remember this logo. Right. So the National Filaria Control Program in the endemic areas started way back in 1955, along with the Malaria Control Program. However, because of a lot of focus on malaria control, there was a limited coverage and limited success of this program. Till 2000, when WHO came up with a global program for elimination of lymphatic filariasis, and it recommended 2 strategies, a 2-pronged strategy of giving annual mass drug administration of DEC, diethyl carbamazine, and those who are already suffering from chronic diseases like elephantiasis or hydrocele because of lymphatic filariasis, to do their morbidity management and disability prevention. Okay, so if you see these 2 strategies, administration of MDA is to be done in all the people, the entire population of the endemic area. So this is a type of primary prevention strategy. And morbidity management, disability prevention, these are methods of tertiary prevention. The disease has already occurred, and now we are trying to reduce the morbidity burden, reduce the disability. So again, from the MCQ point of view, the accelerated plan for elimination of lymphatic filariasis does not talk about secondary prevention strategy. There is no early diagnosis or prompt treatment for lymphatic filariasis. Once filariasis occurs, once elephantiasis occurs, there is no complete treatment. There can only be disability management. So we had secondary prevention as a main strategy for Kala Azar, but there is no secondary prevention strategy for lymphatic filariasis. This is again, you need to remember as an MCQ. So based on the 2002 recommendation of WHO under the Global Program of Elimination of Lymphatic Filariasis, the Government of India used the same strategy in the national program, that is NBBDCP, of starting mass drug administration. So again, when did mass drug administration start in India? It started in 2004 with the NBBDCP. Before that, there was no strategy for mass drug elimination, mass drug administration. And both MDA and MMDP started in 2004. However, when it was started in few districts only. And all the endemic districts, 256 endemic districts, were covered by the 2007. However, there was limited success. Out of 256 districts, there were almost 130 districts which failed to reach the target of less than 1% of microfilarial rate. Hence, there was a limited success, and hence in 2018, an accelerated plan for elimination was launched. In 2019, based on the recommendations of WHO, the triple therapy of IDA, ivermectin, diethyl carbamazine, and albendazole was rolled out in 4 districts. And now the elimination target has been set for the year 2021. There's a very high chance that this target will be shifted ahead. Okay, so this triple therapy IDA is still not given in all the districts. It is launched in few districts. Currently, it is being used, I think, in some 25 districts out of the 256 endemic districts. And maybe in future, this will be scaled up to all the districts. So why do we need IDA? Why is MDA by only DEC, diethyl carbamazine, not adequate? We'll see shortly in the future slides. So what are the general objectives of accelerated plan for elimination of lymphatic filariasis? There are 2 main plans. First is interruption of transmission by preventive chemotherapy, that is annual mass drug administration. And second is your tertiary prevention, that is minimum package of care for those with chronic diseases like hydrocele or elephantiasis. And third is the Government of India thinks that we can target elimination very soon in the next few coming years, and hence there is a approach to preparation of WHO's elimination validation dossier. This is a very fancy name. What it basically means is WHO is given a checklist of when to declare a country as free of lymphatic filariasis. So for being on the dossier, India needs to show less than 1% microfilarial rate at district level for at least 4 years. Once we are able to do that, then WHO can certify India as free of lymphatic filariasis. For polio, this time period was 3 years. For lymphatic filariasis, this time period is 4 years. And in order to showcase it to the world, showcase it to WHO, we have to comply with all their checklist points, and that is why it has been taken up as a objective under the Accelerate plan in 2018. So strategy-wise, there are 2 strategies only that we have seen. That is primary prevention using preventive chemotherapy and tertiary prevention using minimum care package for chronic disease. Okay. So when we talk about lymphatic filariasis accelerated plan, this diagram summarizes what we are talking about. So there are 2 strategies, MDA, that is mass drug administration, and MMDP, that is morbidity management and disability prevention. So for MDA, what we need to do is, we need to start off mapping of uncertain areas. In 2004, when MDA was started, the strategy was every 5 years, we have to give annual MDA for 5 years, and every 5 years, we need to do a survey in the area to see whether transmission has stopped or not. So these surveys are called as TAS, Transmission Assessment Surveys. If you can see the last point here, Transmission Assessment Surveys, TAS, these are done in children 6 to 7 years old. And area-wise, different district-wise thresholds are made that if these transmission assessment surveys show that the prevalence, the microfarad rate is below a threshold level in the 6 to 7 year old children, that means in the past 5 years, we have been able to reduce the transmission to manageable levels. So this is the main strategy of mapping. 5 years, 5 to 6 years of MDA in an area, and then after 5 to 6 years, doing a transmission assessment survey among 6 to 7 year old children. In 2018, a new strategy was used under the accelerated plan. This is called as mini TAS. And this is done for uncertain areas. The TAS, the full TAS is done for all the endemic areas. This mini TAS is done only for uncertain areas. What are uncertain areas? Uncertain areas are some pockets or some fringe areas, like in the endemic area, if it is sharing a border with a non-endemic area, these border areas are uncertain areas. We don't know whether transmission has occurred in those otherwise not endemic areas also. So in these uncertain areas, mini TAS is recommended. This is again for the purpose of, as I said, WHO validation. They require that we do these kind of mini TAS surveys. So in this mini TAS surveys, testing of children in the age group of 9 to 13 years is done using what are called as filariasis test strips. This is a relatively new test which goes for antigen testing. Okay, so for MDA mapping, I talked about two things. One is transmission assessment survey done in 6 to 7 year old children. Other is mini transmission assessment survey done in 9 to 13 year old children. Now both of these TAS and mini TAS are done using this FTS strip test for antigens. And besides this, in adult population also, we do sentinel survey and spot check site tests. Sentinel survey means adult population who are anyways going to a hospital for any other disease, and they're giving their blood for any other disease evaluation. Their bloods are assessed, evaluated for presence of antibodies against filaria. That is called as sentinel surveillance. So there are 2 or 3 major hospitals in that area. RMRI is one of the major hospitals in that area, where all the adults who are coming to the hospital and giving their blood for whatever reason, filaria rate in their blood is assessed. Okay, so mapping for MDA we have seen is done using 3 methods. One is transmission assessment survey in 6 to 7 year old, mini transmission assessment survey in uncertain areas, and antibody survey for adult population in sentinel areas and spot check areas. Okay, and based on these, we find out whether that area is endemic or not. If the area is endemic, we will continue giving MDA strategy, mass drug administration strategy, at an annual basis for at least 5 to 6 years. Once we have done this for at least 5 to 6 years, then we again perform our TAS, that is transmission assessment surveys, and mini TAS, that is mini transmission assessment surveys in uncertain areas. The MDA which is given is called as enhanced when we give DEC plus albendazole. And it is called as IDA triple therapy when we also add ivermectin to it. So currently in all the endemic districts, what is practiced is enhanced MDA, that is diethyl carbamazine plus albendazole. And what is planned for all the districts, but currently it is done only in few districts, is the triple therapy, that is ivermectin plus diethylcarbamazine plus albendazole. And the minimum coverage that is required for enhanced mass drug administration is 65% at district level. If 65% of people are covered with MDA at district level, we say that the coverage of MDA is good enough for prevention of transmission of filariasis. MDA should be avoided in pregnant women, in children below 2 years of age, and others who have very debilitating diseases, because it may have some sort of side effects with other drugs. So considering that, if 65% of coverage is there at district level, that means we will be able to counter the transmission of filaria. So as we had seen, MDA started in 2004. And currently we have not been able to achieve elimination even after more than 15 years of using this because of operational issues, implementation issues, and poor compliance. What do I mean by implementation? Again, the three things that we have seen earlier: supervision, monitoring, evaluation, human resource management, program management, ACSM. All these things will help in improving the implementation and improving the compliance of people for the drug. Right, so India became the first country in Southeast Asia region to adopt this triple therapy, IDA triple therapy. In Southeast Asia region, 2 countries are already declared by WHO who have eliminated filariasis. They are Maldives and Sri Lanka. Both are island states and both have declared filariasis free by WHO. Next is, what are the supplementary interventions which are used along with MDA? MDA is the main intervention in the program. What are the other interventions used? They are integrated vector management, same as those prescribed under malaria. Other is DEC medicated salt. Just like we have iodized salt, similarly there is a DAC medicated salt also, which is promoted for use in these 256 endemic areas. And then there is a plan to collaborate with National Deworming Program, because in the deworming program, albendazole is already given in the schools. So if we collaborate with them and also try to give DEC along with albendazole in schools under the National Deworming Program, we'll be able to effectively have better coverage for MDA. Coming to the second intervention, that is MMDP, Mobility Management and Disability Prevention for chronic diseases. So in this, we have to first do a situation analysis. Situation analysis means who are affected, how many are affected, and are we prepared? Are our hospitals prepared? Are our health staff prepared? Are our doctors prepared in managing this MMDP? In managing the chronic disease. So for situation analysis, we try to identify cases of elephantiasis and hydrocele by line listing. Again, hydrocele is a very, very private disease. Many people will probably not just open up if you go and ask them, do you have hydrocele? So how do we approach it? How do we improve the compliance of MMDP identification? That is again a challenge in these areas. Then there are opportunity for collaborating with leprosy and Kala Azar program for line listing, because in them also identification of those who are suffering from disease and long-term complications are done. So same staff and the same opportunity can be used in those areas where leprosy and Kala Azar are also prevalent. And then we have to prepare a list of beneficiaries or a list of those suffering from chronic disease, that is those having elephantiasis, lymphedema, hydrocele, and this list should be prepared PHC wise. Each and every PHC in these 256 endemic districts should have a list, a line listing of all the people who are suffering from this disease. So again, this might be an MCQ point, that when we're talking about elimination in lymphatic filariasis, we are talking at district level, But when we are talking about line listing, we are talking at PHC level, not at district level. Once we have identified the people, once we have done the situation analysis, then we need to plan our activities for giving them, for providing them minimum care of packages. These minimum care of packages include treatment of acute ADL, that is adenolymphangitis, management of lymphedema, prevention of acute attacks, and providing surgery for hydrocele. The disease has occurred. Now we have to ensure that it does not progress. There are no acute attacks, superimposed attacks on lymphedema. And if there is a debilitating hydrocele, to provide a surgical cure. All these are tertiary prevention initiatives. When we have effectively covered both MDA and MMDP, simultaneously, we have to do this dossier development. That is, we have to ensure that checklist for WHO elimination is filled. Once it is internally validated by Government of India, it will then be externally validated by WHO experts. The surveillance for TAS and MMDP line listing will go hand in hand, at least for the next 4 years after this process. And once for 4 years, no new transmission is there, the microfilaria rate is less than 1%. At that time, WHO will verify that the country has achieved elimination for lymphatic filariasis. So we are still in this pre-dossier development phase. We are just in the starting with the talks of we need to develop the dossier. This is the checklist that we need to fill. And because of the checklist, we have to intensify our line listing for MMDP, and we have to intensify our TAS, Transmission Assessment Survey. Okay. So there are many short forms in the lymphatic filariasis program. It will be a good idea if you remember all these short forms: MMDP, TAS, MDA, IDA, ADL. These are short forms that you need to remember. They may be asked in your MCQs. Lymphatic filariasis, Kala Azar, their national program will probably not come as a long question. It can be either as a small part of the long question or it can be asked as a short note. But there is a really very high chance of getting MCQs from these topics. Okay, I'll not go into details of this. Okay. Next, we come to the National Program for Prevention and Control of Japanese Encephalitis. Okay, so just like dengue and chikungunya, for Japanese encephalitis, we are still not talking about elimination. We are still talking about preventing it and controlling it. Okay. And good thing about JE is we have a vaccine. We have an effective vaccine available. So the main strategy for JE prevention and control is doing the JE vaccination effectively and expanding the services to all the endemic areas. For identifying the endemic areas, we need to have surveillance activities. We need to ensure which areas are endemic or which are not. And rest, all the interventions are very similar to the malaria intervention. Vector control, disease surveillance, advocacy. BCC means behavior change communication, and IEC means information education communication. What is the difference between BCC and IEC? IEC focuses on giving the information. IEC is information education communication, communicating the information and educating. BCC goes one step ahead and ensures that after receiving the information, after the education, there is a behavior change that is occurring. So ensuring that there is a behavior change after giving the information is also very important. So that is a fine difference between BCC and IEC. BCC means behavior change communication, communicating effectively to ensure that the behavior improves. And monitoring and supervision, also ACSM. Then for the national guidelines for clinical management of dengue fever and also the national guidelines for clinical management of chikungunya, there are very limited guidelines for surveillance, very limited guidelines for public health approach to diseases. Mainly the guidelines are for if disease occurs, how do we manage them, how do we diagnose them, how do we treat them. Okay, so I will not go into a lot of details about what are the clinical features, what are the diagnostic features, what are the treatment plans for the disease. All these are given in the document and they will be covered more in detail in your clinical branches, in your medicine classes. So if you see this document of national guidelines, they talk in detail about what is dengue fever, what is dengue hemorrhagic fever, what are the various criteria, what is shock syndrome, what are the case definitions for probable case and a confirmed case. They have given these flowcharts for dengue case classification. If you closely look at this dengue classification, it is very much similar to your influenza classification. Influenza also we talk about category A, B, C. This is very similar to that category A, B, C. If you see here, this talks about severe cases when there is hemorrhage or shock. These cases talk about moderate cases in people with comorbidities or elderly people, and this is in mild cases. It's very similar to how we classify influenza. And just like influenza, whether we do home management, monitoring, or we need to refer to a tertiary care, that is mentioned in this dengue classification. This acute febrile illness for less than 7 days is a little controversial because nowadays dengue and both malaria and dengue present in a very varied manner. The presenting symptom can just be bleeding. It can just be malaise. So acute febrile illness is not required. But yes, from the MCQ perspective and from writing the answers perspective, you need to know that in dengue, usually the acute febrile illness occurs within 7 days of onset. There will be clinical features, there will be examination features, petechial rashes. How do we examine them? How do we diagnose based on the previous graph that I talked about? And then there are also guidelines for management. How do we do volume replacement? How do we do platelet replacement? And what concentration it needs to be done? All these details are there, but we will not be discussing these details in this class. Similarly for chikungunya, probable case definitions, confirmed case definitions, laboratory case definitions are given. This is important. This can be asked again, mainly in your clinical branches. Sometimes it may be asked in community medicine also, that at a primary care center, how do you differentiate between chikungunya and dengue? So fever onset, although it is written as the first step, is usually not very helpful in differentiating between chikungunya and dengue at field level. What is mainly helpful is the type of rash. If it's a petechial rash, it goes more in favor of dengue than chikungunya. All the other symptoms are almost similar in both the disease. Shock and severe disease again is more common in dengue than in chikungunya. Leukopenia is more common in chikungunya than in dengue, although leukopenia is seen in all the viral diseases, so it can occur in dengue also, but it is seen more in chikungunya. Thrombocytopenia is classical of dengue. Hematocrit, again, raised hematocrit is classical of dengue. So these two are diagnostic of dengue fever. Thrombocytopenia with raised hematocrit. Again, MCQ point of view, and even clinically, in the field practice also, when you're actually examining patients, just by seeing these two parameters, you can have a high index of suspicion that the patient might be suffering from dengue. In our area, in Jodhpur and Rajasthan, dengue and chikungunya both are prevalent, both are commonly seen. This is an algorithm which is given in French guidelines. I find it to be a very useful flowchart for assessment of chikungunya, for management of chikungunya. So I will briefly discuss about it. It is not very imperative that you know this because it is not given in the Indian guidelines. So whenever there is a suspicion of chikungunya because of clinical features, we have to assess whether there is an immediate danger. That is, where there is a danger to your airway, breathing or circulation. If yes, then we need to go for emergency treatment. If there is no danger to your ABCs, then we go and ask whether there is any sort of accompanying atypical feature. Along with fever or body ache, are there any organ failures? Is there a bleeding? Is there a dehydration with fever? If all these things are there, then we need to consider hospital admission. Again, these are French guidelines. In Indian settings, probably we'll have to reevaluate which patients we need to send for admission, which patients can be managed domiciliary. If there's a pregnancy, we need to take an obstetrician's advice as to how do we go about it. If there are other risk factors like whether it's a neonate or there's a history of febrile convulsions, seizures, elderly patients, any other chronic disease, person who is staying alone, in these cases, we need to closely follow up for progression of disease. And after this also, if the diagnosis is not certain and after differential diagnosis also everything else is negative, we need to take a specialist advice, we need to take an ID specialist advice, and maybe we can start the patient on empirical therapy, supportive therapy. Anyways, in chikungunya and dengue, the therapy is supportive, there is no specific treatment available. Right, so that is all from my side. In dengue, there is a new vaccine which is available, Dengvaxia. Again, it is in pilot phase in few countries, currently not recommended in India. Maybe asked to you, maybe it will be asked to you in your exam. So dengue and malaria are two diseases which have a vaccine. Chikungunya vaccine is also there, but it is not yet in human trials. It is still under study. Other diseases still don't have any vaccine available. Right, I will be happy to take any doubts that you have. No doubts? Have I managed to put you in sleep, put you to sleep? The lecture was so boring. Great question. So Satvik is asking, how do we decide whether a vaccine is required or not? So the question that we're trying to ask is essentially whether the disease is of public health importance or not. So whether a disease is of public health importance or not is decided by three things. First is prevalence or incidence of the disease. Second is prevalence or incidence of deaths because of the disease. And third is DALYs, disability adjusted life years. That is, how much is the debility caused by the disease. Now, in case of malaria, dengue, chikungunya, and all these vector-borne diseases, maybe malaria and dengue are two diseases which are highly prevalent. There is a high transmission rate, and they cause a lot of mortality. And then there are certain pockets of filaria and certain pockets of Kala Azar where the morbidity and mortality because of these diseases are seen. So when we're talking about India as a nation, maybe malaria and dengue are important from the entire country perspective. And when we're talking about other diseases like JE, if a JE vaccine is available, which is actually available, it is given in only specific areas where it is considered as a public health problem because of its high prevalence of morbidity, mortality, and disability. Similarly, filaria interventions, vaccine or otherwise, whatever interventions are available will be decided based on their prevalence of disease, mortality, and DALYs. Okay, Amisha, you have said that API of more than or equal to 5. So these are the guidelines which were in vogue before 2017. The 2012 NSP talked about API less than 2, 2 to 5, and more than 5. And this API was calculated at state level. However, since 2017 onwards, the program has changed. And now we classify as per API less than 1, 1 to 2, and more than 2. So LLINs are definitely recommended in areas of API more than 2 when we are talking about district level classification. And it is also now recommended in areas of API 1 to 2. Which edition of PARC are you reading, Amisha? So this is the slide I'm talking about. This is the categorization which has been given in 2017 under the National Strategic Plan. Category 2 is API 1 to 2, and this is more than 2. So yes, then that means that park must not have updated its recommendations. Again, park has talked about malaria at one place and the malaria program at another place. Maybe it has updated the guidelines at the malaria program page, but not updated the guidelines at the malaria page. Great, we have still 10 more minutes if there are any more doubts. Right, no more doubts. Let's talk laterally. How are you guys coping up in this situation? We guys here are very busy. It is an effort to come and actually prepare for a lecture because I don't want to do a half-hearted work. But otherwise, how are you guys doing? Are you guys busy? Are you guys enjoying? Are you afraid? Are you tense, depressed, or having a ball of a time? इतना time कब मिलता है? You know, this reminds me of Harry Potter. He so desperately wants to go back to Hogwarts. But this is also a great opportunity of exploring all your other hobbies and lateral things. Like, you know, when I was doing my post-graduation after MBBS, I involved myself in building up websites to help patients in organizing their data online. During my MBBS time, I used to do all sorts of lateral reading. I used to read all sorts of novels. So maybe, you know, this is a good time for you to explore all your other hobbies. Otherwise, I think when you guys are here, you hardly get any time for your hobbies. So it except Amisha and Satvik, other people I think are too bored. So if there are no other doubts, we'll end this session. This is my email ID. If you have any doubts, you can email me anytime. Thanks a lot. Representatives are only to give voices to, you know, what is needed. बाकी टाइम तो खुद बोल सकते हैं. चलो, I'll take a leave now. Thanks a lot.